Well, thank you as a crowd for joining us today on a very complicated and sometimes difficult subject to talk about. So first of all, to introduce myself, I'm Laura Elvin. I'm the founder of I Use Genius, which is a 360-degree positive impact consultancy. So why, as a positive impact consultant, should I be concerned at all with fertility and fertility privilege in the first place? Why should I care? Well, the World Health Organization released its first report in April 2023, which revealed that 1 in 6 people worldwide will experience infertility. That, coupled with the fact that male fertility has been on the decline since 1970 and has declined by 50%, is also concerning. But further to that, my first conversation with Dr. Sara Matthews really illuminated the fact that infertility in itself also poses gargantuan mental health issues. And actually, 1 in 10 people who are undergoing infertility treatments will experience thinking about suicide all the time. First question to Dr. Sara. As a leading gynecologist in this country, an expert on IVF, what are your perspectives on infertility as actually a form of trauma?
Infertility provides a profound effect on people's mental health. And I think the fact that worldwide the rates of infertility are increasing and are expected to continue to increase in the next 10 years means that we have to sit up and listen. Because for women and men both having fertility treatment, there are huge rates of depression, feelings of isolation, loneliness, and of course it's a very personal problem that people don't feel they can discuss in the workplace or with friends and family. It has a severe impact on relationships in a lot of cases, and of course because the funding capability in most countries, and in particular in the UK, is so poor, it comes with financial hardship as well. And in terms of the men, a lot of the focus tends to be towards the women, and of course there is a doubling of suicide in women with long-term infertility problems over normal. But men also have a 40% incidence of mental health issues, the 1 in 3 chance of it affecting their work, and a 60% chance of it affecting the relationship. And for men, it's quite often more difficult to discuss. Men feel they have to be the strong one, and they feel a bit disempowered because it seems to be that a gynecologist is doing all these things to their partner, and they are not really a part of it so much, but it's their partner that ends up being filled up with hormones and going for multiple hospital appointments, having blood tests, whereas they have to stand back and just be strong, and it can be really, really difficult.
Yeah. So we've certainly established that there are huge implications for mental health, and what occurs to me is that then even within that context, couples and individuals might be faced with huge economic shock with what comes next. And certainly the Maven Clinic found that 97% of people that arrive at the clinic don't have an idea of the economic costs that they're about to be met with. So Tess, as the founder of Fertility, which is an at-home ICI intervention for 1/20th the cost of IVF, can you tell us a little bit about why you thought to start Bayer in the first place and in relation to the economic costs?
For sure. I think if you look at the cost of IVF and you look at the amount of money that people spend on fertility care, in the US, for example, the average spend on IVF is $61,000. Now, the average salary in the US is $59,000. So I'll let you do the math on how affordable it is to build a family in the US if you're struggling. If you just look at the rates of infertility, especially sort of speaking about, again, the US, 1 in 4, the CDC just updated their guidelines, 1 in 4 will take longer than a year to conceive. Now, it's an incredibly frustrating experience. You can go to Turkey and get a round of IVF for 1,700 euros. You can go to Spain, it's 3,500 euros. You can stay in the UK, where the average spend is £13,700. But these numbers don't add up. It's not enough to offer payment solutions and buy now, pay later products. We have to start creating treatments that are fundamentally at a different price point to what exists already today.
Yep, understood. Well, thank you for doing that. So, Dr. Avizo, I understand you are the director at the Women's Health Innovation Center at Sheba, which is one of the most pioneering hospitals in the world, and your specialism as well is looking at the pregnancy continuum. Can you explain how care within the fertility continuum is also important to increase access for and provide?
So, the fertility privileges are really important and appropriate. However, they can't be standalone. Because what I call the pregnancy continuum or the journey to parenthood is not only fertility, it's the pregnancy and it's the postpartum period. And we know that many of the indications for fertility care come together with a high-risk pregnancy. Women with PCOS, with endometriosis, or even if they don't have high-risk conditions, if the pregnancy becomes a twin pregnancy or triplet pregnancy, it's increased risk for high-risk pregnancy. And if we only provide fertility privilege, and we do not do it as part of general access to care during pregnancy and postpartum, it's not enough. And we currently know that more than fertility, more than the pregnancy, the postpartum period is the most dangerous period. And we know, let's say in the United States, that the highest risk of maternal death is a 2 to 3-fold higher risk of maternal death among Black Americans. So clearly we have to improve general access to care for women.
Okay, so there's a very clear disparity there for Black women. That leads on very nicely to Dr. Annabel's expertise. I first discovered Dr. Annabel via her work as an author of the book Divided, which looks at systemic racism and how that is embedded into the healthcare system. She's also a Harold Moody Scholar at King's College and also the founder of Reproductive Justice Initiative, so an expert on these particular communities and how these issues affect them. In your lens and from your lens, how do you think these communities are affected and what do we need to concern ourselves with?
Yep, so I think when you look at how reproductive health access is often discussed and look at the historical legacy of who has fought for it and the rights that have been won, the key concerns are often around choice and the idea that if we improve access, then people can choose what's right for them. So around the time that we were looking at defining reproductive health more clearly in the early 90s at the International Population Development Conference in Cairo, you had a group of Black and Indigenous women, particularly in America, saying that that idea of choice is not sufficient for our experiences. We need to look at structural injustices because just talking about choice is not enough. So they coined the term reproductive justice, and they're very much talking about the right to have children, the right not to have children, and the right to raise children in healthy environments. So what that means is we have to think about when we're producing technologies, are we just saying, okay, we produce it, people can opt in? No, we have to say that people may not be able to opt in because they don't have the resources, and they also might have concerns about what happens to their children in terms of when they put them into the world. Will they be able to live safely? We also need to expand our understanding of what's deemed a good parent. So academics like Hill Collins have talked about the idea that some people in some demographics, particularly Black working class women, are seen as kind of welfare queens or reliant on the state. So then our reproduction is not seen as favourable for society. So that also governs if people are willing to give us access as well.
Okay. Yeah, it's a little bit disconcerting how that plays out at large, and I certainly recommend reading Dr. Annabel's book, and I'm not just saying that because I'm speaking to you on a panel, I'm saying that because I think it's imperative reading. So looking at the global situation and in response to the WHO's findings, what do we think are the key aspects to concern ourselves with addressing this as an issue globally and at large? And to kick us off, Dr. Sara, can you actually tell us in detail the equation, the economic equation that underlies IVF procedures and how exactly that's done and what exact prejudices, say, are embedded in those economic equations?
Laura, that's a really difficult question to answer. And I'm no economist.
Yeah.
But when it comes, IVF is an expensive treatment, and it's expensive because it involves advancing scientific processes, very super skilled doctors, expensive equipment, expensive consumables, and an infrastructure with regulation that is essential to make sure that it's managed in an environment in the safest way possible. And so, and that has been increasing over the last sort of 20 years or so in particular. When the WHO brought out their announcement in March this year as an update to say, look, guys, infertility is a hugely increasing problem. It doesn't discriminate between developing and developed countries. It's increasing in both, and it is becoming more of a problem, especially since our reproductive rate has gone down to 0.88. So we're becoming a society of older people with less younger people coming into the world. And that comes into the economic equation of when providing fertility treatment is a good idea for a nation. The WHO have indicated that they want all governments to actively consider implementing a fertility protocol into a policy into their financial structure for healthcare. And yes, there are major other considerations, especially in developing countries where the priority is maternal mortality and child mortality. How does an expensive treatment like infertility, IVF fit into that when there are other priorities for healthcare that seem to be important, but actually it is now at the point where it has to be incorporated into any healthcare system. And so the challenge for us is to try and see how we can reduce the costs for IVF, especially in the developing world, and to increase funding in developed countries. And ways that we've looked at doing that are things like simplifying culture conditions, having mobile units that will go from place to place in rural areas. Accessibility is a big issue.
Yep.
And looking at preventing infertility in the first place and educating people about their fertility so that people know in their early 20s that there's a biological clock, both men and women, and people are aware of the effect that STIs, sexually transmitted infections, can have on your fertility. So there's education, maybe providing more bread and butter investigations and lower grade treatments, because certainly if I look, and I'm jumping now to the situation in the UK, because of funding pressures and economic calculations, a lot of the previous investigations that people would have had to holistically investigate their infertility have been lost. Because it doesn't make economic sense. We simply just put people on a waiting list for IVF. Intrauterine insemination, ovulation induction are less considered because they're more clinic intense. They require more visits to hospital, and so economically, even though IVF is much more invasive, you get more bang for your buck, as it were. And I do think that we need to consider all of that. But there are so many questions to answer on a global scale.
Yes,
I would be here all day.
Yeah.
And I would need lots of help to try and make sense of it.
We'll unpick that further, I'm sure.
But at least to get it out there that it is a big issue, and it's global, and it's increasing, and we need to address it and do something about it.
Yeah, so certainly the underlying economics of IVF are very interesting to look into, and how we can perhaps provide it for more people. But actually, the very definition of infertility was brought up by Dr. Annabel, and you actually questioned the definition of infertility in the first place by the WHO, and further asked me really, well, is it actually the underlying criteria that in itself is flawed, i.e. it's put into aspects of BMI, etc., which reflects differently among different groups. So can you talk a little bit about the definition of infertility and the metrics used?
So Dr. Sara has touched upon this slightly, but in the WHO, the World Health Organization report released earlier this year, they picked up on the fact that infertility is very difficult to measure, and in terms of in the research that's been put out globally, it's very variable, whether people are self-reporting, whether you're following people, and we do need to, as academics, be more robust in our definition, because if you can't quantify a problem, then it's much harder to address. So we do need to, that's one way of pushing this conversation forward, and then we can say who has access to the diagnostics, and we can spread the resources there. In the UK, we see issues in terms of how fertility guidelines are drawn up. So BPAS, for example, did a report on the postcode lottery of accessing IVF care in the UK. When you do then get to clinic, it's very variable who the local clinical guidelines. So some people have a cutoff if you've had a kid from another relationship. If your BMI is over 30, you can't get treatment. Mana Mustagib, an academic at LSE, has done fabulous work on this. About a quarter of IVF guidelines have a BMI cutoff, and the evidence around BMI in particular in medicine is quite contested. And the American Association of Physicians recently actually said that physicians shouldn't just be relying on BMI because it's so variable across populations and it's not reflective of your overall condition. So there's a lot of work to be done.
Yeah, exactly. Well, I certainly wanted to get the point across, and thank you for doing so, of the particular groups that are deemed, as worthy, shall we say, to access these fertility treatments. So Tess, we touched a little bit on what BAME does. The WHO specifically called out for democratized access to fertility. So I think you're the right expert to ask, how exactly can we democratize access to fertility, and how are you doing so potentially?
Yeah, I think the one thing that we focus on is what blocks people from accessing fertility care, which, in the NHS can be BMI, it can be where you live, it can be all sorts of completely unrelated factors that feel very unfair, but where we focus is cost. So what we look at doing is creating a treatment that used to be performed in clinics up until IVF was developed. And we've brought it back and offered it as an earlier stage intervention where you can access 3 cycles of this for about a 20th the cost of IVF. So when we talk about fertility care, everyone immediately thinks of IVF. They think of a fertility clinic. But that really is further on in the care pathway. So for us, when we think about democratizing access to fertility care, the step change that we're trying to drive is to actually reinvent the care pathway. Look a little earlier than what happens in the IVF clinic. Try something earlier in the care pathway that is more easily accessible for more people.
Brilliant. And actually, Dr. Avi, you pulled me up on my initial questions to you, which were really in response to the WHO, how can we address this on a global scale? And you pointed out that you don't think we can even discuss it in terms of a global question. And as part of explaining why you think that's the case, can you illuminate a bit on how we can have positive impact at a local level, in particular covering your project in Hebron with the WHO?
Yes. So we'll start with the challenge. I agree with Tess. Affordable care is part of improving global care, and I'll also talk about remote care doing it. However, we must admit that a lot of our innovation, especially recent AI and generative AI, it allows us to provide information on a global scale. It doesn't allow us to provide better care in a global scale. And when we talk about improving global health, we think about Africa. Even in the United States, currently, some women don't have access to something that is more foundational than fertility privilege. They don't have access to abortion if they want. So there's a lot to do with global care. We at Sheba, one of our most exciting projects, we took the remote care service that we developed for patients at Tel Aviv, which is premium care, giving every patient her own fetal monitor, her own ultrasound probe, so we can follow her at home or at work. We said, can we pivot this service to provide care to women in Hebron and Khalil area that don't have care at all. Some of them just come and give birth. They don't even do the glucose test. They don't know they have gestational diabetes. And we, in collaboration with our Palestinian colleagues from El Ahli Hospital, we developed a service of kind of an A-team going between villages. And first, it's more than medicine. It's connecting between people. And the other thing is, technology allows us, when they go between villages and see the patients, we are able to see the same patients together with them. We are at Sheba, they are at an Ali hospital, we see the patient in some village, we're able to discuss. So innovation can, to some extent, improve global care.
Well, it certainly occurs to me that innovations and projects like that should certainly receive funding and support, and including from policy. So the person who gave context to this conversation was a lady called Elizabeth Day, who is an author and was giving an interview for the Sunday Times and coined the term fertility privilege. And it certainly helps that celebrities, write books, talk about these issues, and bring light to something which is otherwise residing in dark spaces. So why do you think it's taken so long for people to pay attention to this issue, for it to receive any funding, for it to develop in terms of policy that supports it? Do you think perhaps it's an education problem, Dr. Sara?
Education is certainly a huge issue. I think if you look at sex education as teenagers, it's all about how not to get pregnant.
Yes.
And in fact, we come from a generation where you stop the pill in your 30s and you think, oh my God, I'm off the pill, I'll be pregnant, and you're not. Because nobody's actually explained the other side of the not getting pregnant bit and how difficult it can be sometimes to get pregnant. So education is the key, education at school level, education of people at large, and also in workplaces. To give a little bit more space to people who are having, and consideration to people who are having fertility treatment. But when it comes down to organising treatments and who gets treatments in the UK, it was a political hot potato in the early 2000s when funding was first available for this scientific research thing that was gradually brought into clinical practice. And of course, in the UK, we invented IVF. We should be the leaders and the representatives worldwide of what's possible. But unfortunately, because there was so much controversy about it, of course less so now, the government decided not to make a centralised protocol on who should get treatment and who shouldn't. They decided to devolve it all to local commissioners and local authorities, which meant that it introduced this postcode lottery, which means that now, if you live in Brighton, you can get 3 IVF-funded cycles up to the age of 40, and if your egg supply is good enough between 40 and 42, you can have 1 fully funded. But if you live next door in Canterbury, you can only have 2 cycles, and you must be under 40. And if you move to Southampton, you can only have 1 cycle, and only if you're under 35. And that is the awful fact of funding in the UK. It is completely unfair. Only 20% of the cycles of IVF in England are funded. In Scotland, it's 67%.
Yes.
So this huge disparity that's so incredibly unfair. And the local authorities have made their own rules about what they think is an appropriate BMI. And certainly, I don't know of anywhere in the world, now maybe in Israel, because they're so forward-thinking with their fertility treatment, but in anywhere that I know in the world, there is no funding available for people who have had a child and cannot become pregnant again, because secondary infertility is as common as primary infertility.
Yeah. And certainly the age cutoff is interesting, considering that the age that people are having children is getting later and later.
Yeah.
I think the average in the UK is 31 now. So Tess, I'm going to denote you the voice of Femtech for the purposes of the panel, I'm afraid. So Femtech seeks to solve the issues and to fill the gaps that the public sector, may leave behind. And it's certainly reached some milestones. In 2021, we raised 1 billion as a sector. In 2022 Q2, we raised 3.86 billion, which was a huge milestone, and may seem like a lot to a lot of people, but unfortunately, if we put that into context, it pales in insignificance to, for example, 210 billion, which was invested in fintech, very close sounding, but not quite the same, in just 1 year. So in light of those kinds of stats, Tess, can you tell me a bit about the funding environment, the policy environment for the femtech space? Have you met with any hurdles? How have you found the process?
Yeah, so I think we all know that VC funding for female founders is 1.9% down from a historic high of, I think, around 2.4. So not great. And a lot of the companies addressing inequalities and sort of inequity in fertility and women's health are female-led teams, female founders. So I think from a funding perspective, there's just not enough going into innovation, going into solutions to these problems. And that's certainly something that we've found.
Yeah. In terms of policy as well, I want to shift on to something that I had no idea about that Dr. Annabel taught me on. Hi.
Yeah.
Yes.
Okay, I think the clock actually started late. It started at 24 minutes, but...
I know. I'm so sorry, everyone, because we did start late, unfortunately, so I suppose we'll have to kind of cut it off there. Essentially, the points that we were going to get across were that the policy environment in the UK and with regards to surrogacy are rather interesting. So if you want to follow up with any of us on those particular points, then you certainly should. And the fundamentals here are that the UK has a lot to learn, and certainly from countries such as Israel, in terms of how to match funding policy and meet innovation.
Thank you.
Thank you.